we request Dr. Rajeshkumar Hugar to present his paper on unusual presentations of Rhinosporidiosis.
Good afternoon, everybody. Myself, Dr. Rajeshkumar Hugar. I will be presenting about the unusual presentations of Rhinosporidiosis case series. So, Rhinosporidiosis is a granulomatous infection in the nasal, usually in the nasal cavity. It presents with a polypoidal tumor-like masses, which are caused by Rhinosporidium seaberi. Rhinosporidium seaberi in the previously it has been classified as fungus or cyanobacterium, and currently it is classified as a protist under the class Mesomycetozoa. It usually affects the nose and nasopharynx, but it can also involve lips, palate, uvula, conjunctiva, larynx, and trachea, skin, penis, and vagina, even bone. So majority of cases, almost more than 90%, they are found in tropical areas like India, Sri Lanka, and South America. In India, it is mostly seen in Tamil Nadu, West Bengal, and Andhra Pradesh, and it is mostly more common in males than in females, because males they are working outside when they are exposed to the organism which are present in soil or ponds, and there is no specified modes of transmission, but suggested modes of transmission are stagnant lakes, ponds, as well as contaminated soil and sand. And the other modes of infection are auto-infection, which can happen from endospore spillage during the surgery, or in trauma, or hematogenous dissemination, or lymphatic spread, and sexual transmission is there, even though rare. In nose, it presents as a reddish strawberry-like polypoidal mass. Strawberry means the white spots refer to the sporangia against the congested background of the vascular mucosa. And usual presentation will be nasal obstruction and epistaxis, but it can vary. If the lesion occurs in skin, it can present as a chronic ulcer, or if it presents in the nasolacrimal duct area, it can present as epiphora, like that. Depending on the site of the lesion, the symptoms vary. So diagnosis is usually made by clinical examination and diagnostic nasal endoscopy, but confirmation will be histopathological examination. So this is the life cycle of the Rhinosporidium seaberi. It starts with juvenile sporangium, which increases in size and goes on dividing to become intermediate sporangia. That division can happen either centrifugal or in centripetal direction, and finally it becomes mature sporangia, and they developed into mature endospore. As you can see, the residual matrix is covering the mature endospores in a comet tail shape, and finally when the pressure builds up too much, and they are released, forming the free endospore. Coming to the histopathological examination, there are three things to be noted. One is hyperplastic epithelium, that is stratified squamous, and there will be varying in degree of hyperplasticity. And there will be, second thing will be sporangium, you can appreciate, filled with sporangiopores, and third will be inflammatory cells filled with lymphocyte, plasma cells, and macrophages, along with vascular mucosa. And treatment will be by surgical excision of the polyp or the lesion, which remains the mainstay of treatment, and cauterization of the base of the excised polyp is to be done, and dapsone is the only drug with proven efficacy when used as an adjunct to surgery. So we will see our case reports. There are three case reports. First one is here. A 37-year-old male patient who presented with sensation of mass per throat for 3 to 4 months, intermittent difficulty in breathing for 15 to 20 days, and difficulty in swallowing for both solids and liquids for 4 days. So he came, and on oral examination we could see the pinkish polypoidal mass, and in ideal it was showing a pedunculated polypoidal mass hanging from the left lateral wall of the pharynx. The given image is of direct laryngoscopy. So when we examined, nose and nasopharynx were normal. There was no lymphoidal involvement as such, and so patient was posted for DL-scopy with biopsy, and his sample was sent for histopathological examination, which proved rhinosporidiosis. So in our first case, the patient presented with dysphagia. So in this case, we just clamped and hemostatic suture was pushed. Cauterization couldn't be done in this. And histopathological examination shows that stratified mucosa, hyperplastic mucosa, and there are various stages of sporangiophores. And second case, it hits a 45-year-old male patient presented with history of epiphora and purulent discharge from left eye since 3 months. So initially mucocele with the chronic dacrocystitis was diagnosed, but in intraop, when we remove the medial wall of nasolacrimal duct, we could appreciate a polypoidal congested mass protruding it. When we sent it for histopathology, rhinosporidiosis proved. So after that, eventually patient was subjected to dacrocystectomy by ophthalmology department for total clearance of the disease process. This is a HP slide, shows a HP of this current case, which is done in PAS stain, periodic acid skip stain, which shows varying degree of sporangiospores. And third case is 56 years old woman who presented with a 4-month history of progressively increasing noisy breathing. The patient had been diagnosed with nasal rhinosporidiosis 12 years earlier, and she had undergone nasal surgery 3 times to treat recurrences. So this is a case of a 56-year-old woman who had recurrence of rhinosporidiosis after 12 years of her initial episode of infection. So we did a flexible nasopharyngeal laryngoscopic, and there was a mass arising from the right ventricular band occluding the glottis, and histopathology proved to be rhinosporidiosis. So in our first case, we saw the patient presented with dysphagia. In second case, patient presented with epiphora, and in third case, patient presented with noisy breathing. So nasal and extranasal rhinosporidiosis, they can have an unusual presentation, and the high index of suspicion is with the relevant clinical presentation, and personal history should be kept in mind, as effective surgery is the only treatment. So if you are aware about the condition, we can reduce the chances of its recurrences and can provide a significant relief to all the patients. Thank you.
Any questions, please? Now I request Dr. Sachin Deshmukh sir to felicitate Dr. Rajeshkumar Hugar.